Typically what works nice is the prone pillow. You guys have seen that blue pillow that's laying around. I use that a lot with patients, or if you have a table with a cutout, that works pretty well. Is it right there? Right there. I'm not going to use it because you guys won't have it. But the other way of doing this really that I often do is just have people put their forehead on their arms. So they're just neutral on their arms. Forehead on their arms. Slide down towards your feet. There we go. Right. But kind of like more, can you do it more like this for me? Wow.
Simulating a real patient.
So what we're doing is we're just trying to keep the head neutral. Now a lot of people say, well, now you're engaging muscle here, and that sometimes has some issues. But from a real quick perspective, I won't often run and go get that thing and look all over the clinic for it. I'll just do this. So what we're going to do is essentially we're going to kind of, our mobilizing contact here is this right here. So it's kind of our two thumbs back to back. And there's a couple reasons for that. Number one, it gives a broader contact area, so it's not quite as pokey, right? And it also supports your thumbs, so it makes your thumbs not fail before you're 40 years old, right? So it kind of supports you, it's good for you, it's good for them. The challenge is that sometimes it's a little bit more challenging to perceive motion with both thumbs like that. So both of these thumbs are going to end up on the spinous processes of the cervical spine. And I recommend starting at a certain spot. I'm going to recommend starting low. I think it's easier to more definitively identify C6 and C7. So we've kind of identified where those guys are, and we're going to kind of start on C7 and kind of work our way up. Okay? Now, what's important is to gain contact and to have good contact and not be pushing on the surface. So if I'm doing something like this, that just doesn't feel good. But if I'm kind of getting my fingers in there and kind of making contact, taking up the slack, and then I push, usually it's tolerated a little bit better. Okay? The way that we're going to do that in the neck that really works pretty nicely is I'm going to kind of create a mobilization gutter. Okay? So I'm going to kind of think about taking my hands and taking the cervical spine musculature and kind of almost folding it up and in. Kind of like you're making some sort of, I don't know, pastry or something, right? I'm kind of taking the dough and I'm kind of like, you know, I'm kind of rolling it inward like this. So I'm moving my thumbs inward, but I'm creating this little bit of a gutter. We're going to call it a mobilization gutter. In this case, it's for evaluative purposes, but we're going to transition this immediately into a mobilization technique. Okay, so this will become a technique. So we're down here, we're going to pick that level. So if you watch my hands, I'm going to kind of take up and draw up the skin a little bit and draw up the muscles a little bit so that as I'm kind of, you know, working on this, I'm kind of holding those kind of paravertebral muscles in my fingers. They're kind of pinched between my fingers and my thumb. And I'm kind of drawing that upward in a fashion that creates this little gutter. And you can see, I think, nicely in the photo there that there's that little bit of a gutter that's kind of created there. And so both of my thumbs now, back to back, are on his spinous process. Not a lot of soft tissue over these guys, so it's not the most comfortable thing. So if you elicit symptoms, make sure it's not you poking, but it's actually symptoms from the motion you're creating. And I'll kind of ask them several questions about that to make sure it's just not me, you know, that it's uncomfortable in the spinous process, but that it's indeed, you know, that I'm creating motion that's uncomfortable. Your position, body-wise, is you're in a staggered position, so one foot's in front of the other, and really all of your weight is on your front leg, and you're kind of leaning and putting weight onto the table. You're kind of leaning onto the table, basically. So again, if I had, you know, bronchitis, my nose would be dripping right where I'm mobilizing. So you're not over here, right? PT is a contact sport, right? So we're like right in here like this. So my arms are kind of, you know, vertical. I'm looking right over the spot that I'm mobilizing, right? And then I'm just going to basically take up the slack, and I'm just going to push. Okay? Now, one other thing before we kind of break up and try this. This joint is not the hip joint, right? This joint is also not the lumbar segment joint. This joint is a little tiny baby joint. Okay? So you're going to make a lot of your classmates unhappy if you don't remember that. Because when you go in and start doing this, we don't need a lot of force. In fact, in grade 1 mobilization in the cervical spine, Jeffrey Maitland defines it as if you had a little fly sitting on the cervical spine in grade 1 would be you're bending his knees. Okay? If flies have knees. So that's how little force we're talking about. Very, very minimal amounts of force. It's a little tiny joint. All right? So let's remember that it's not, you know, one of the bigger joints we've worked with before. It's the reason actually why we're doing this now and why we didn't do it first and why we didn't do it last year. Because there's some handling that you want to make sure you're appreciating here that you guys have needed some time to acquire. So nice and gentle. And what are we looking for? I could pretend to tell you that we're looking for motion and certainly that would be fine if you can feel some restrictions in motion. We're going to hang our hat on reproduction of symptoms. And it's really just like the patient was sitting a minute ago, and we were able to reproduce their pain. This is a really nice way for me to like zero in. Another patient yesterday, honestly, I'm not making these patients up, just great examples of how the clinical relates to what we're teaching. Came in yesterday, car accident, getting subscapular pain that's referred from her neck. When I was off to the right of her C5, and I was applying force, just as I'm doing now, over the transverse process, I was reproducing her subscapular pain. And the more I did, the less pain she had. So I kept doing it, and by the time I was done with about 5 to 6 repetitions of those, the subscapular pain had diminished. So just kind of looking at, we found the spot. We found one of the spots that's involved in her particular case. So it's kind of cool to see how some of those things help us and guide us. Okay, so that is mid-cervical. So here we're going C7 just up to C3. We have specialized ones for C1 and C2.